Hi, everyone. Thank you for the opportunity to present to you today about RL6 reporting and our RL6 electronic reporting system. My name is Adam Paglioni. For those of you who don't know me, I am Director of Legal Affairs, Risk, Health Information, and Chief Privacy Officer for Windsor Regional. And I'm delighted today to provide this in-service to you virtually about something important, a function of our hospital which helps support patient care, reviewing of our processes, and overall improving the quality of care that we provide. I don't expect to say anything to you today that you don't already know. This is meant as a refresher on RL6 reporting, and it comes to you as a recommendation from a QSIPA, which we held to improve patient care. So without any further ado, I wanted to dive into RL6 reporting and provide you some helpful information. Firstly, why are we reporting risks in RL6? What is the purpose of that, and why are we doing it? It's important to know that the purpose of RL6 reporting reflects our commitment at Windsor Regional to ensuring that all circumstances that affect or impact patient, employee, or visitor safety, or that can compromise the quality of care that we provide, are promptly and thoroughly reported within all departments and services across the organization. Reporting and documenting such events allows Windsor Regional to review and understanding the systems we have, the processes, and actions that underlie an event. And this is an opportunity for us to identify gaps in our processes or policies to improve patient care. And how does that happen? How does RL6 reporting actually improve patient care or the care that we provide? Through that commitment, we undertake processes, quality improvement measures that can reduce the probability of a reoccurrence and can actually improve patient and employee safety while improving as well quality of care. This includes adverse events, no harm incidences, and near misses. And we're going to learn more about each one of those in a moment. The incident classification denoted at the time of reporting is selected by the user, the individual using RL6. And this reporting of the incident based on a perception that the user has of the event and the classification of it. Let's dive into the differences in the types of events that are reported. We know we are absolutely identifying and recording through our RL6 reporting software adverse events. But what is an adverse event? Please remember that an adverse event is a result of an unintended harm to the patient that's related to care or services provided to the patient, rather than the patient's underlying medical condition. This is important because we want to make sure that the events that we're identifying and reporting are not due to the underlying medical condition of the patient, but instead a process error or something related to the care or the service that we provide. A no harm incident. This is an incident with the potential for harm, and that harm reaches the patient, but thankfully no apparent harm results. These are also important to capture because it helps us have a well-rounded understanding of our policies and our ability to scrutinize them and identify gaps, even if harm didn't actually reach the patient. Then lastly, the near miss incident. This type of event has a potential for harm that does not reach the patient, and that thankfully due to timely intervention. So these near misses, I like to recategorize these. I often call them good catches, because this is something that we've caught. Thankfully, it didn't reach the patient. We intervened in time, but we still want to review those and make sure that they're recorded within RL6 software. Many of you all have likely seen the software. I thought we would do a screenshot just to take you through some of the categories. In this case, I chose a surgery or procedure event. And then, as you know, you have to choose certainly all the things that are asterisked, but we want to make sure that we're providing quality information so that we're not just recording it, but we can have meaningful change due to the information that you're submitting as a user. So you want to make sure you've identified the person that's been affected, the severity level of the harm, and we're going to go through those in a minute. What injury occurred, if any, and were there any equipment or other things that were involved, and then a brief factual description of the event, and so on and so on. Severity levels are really important. We want to make sure that we are accurate in the severity level that we are assessing the risk, the event with. And this is up to the user. It is the perception of the user at the time. But I want to go through each one. And of course, they increase in level of severity as we go further down the list from A to I. And A to D, categories A, B, C, and D, are all no harm incidences. So harm doesn't reach the patient in A, B, C, or D, but we still want to know the differences between those four. Category A, this is the circumstances of an event that have the capacity to cause harm, but that harm did not reach the patient, thankfully. Category B, this is an event that occurred and it did not reach the patient, but again, it had the capacity to cause harm. Category C, this is an event or an error that occurs and it does reach the patient, but it did not cause harm, thankfully. Category D, this is an event or an error that occurred and it reached the patient. It required some monitoring to confirm that no harm had reached the patient. And through that intervention, that monitoring, and that includes any observations physiologically or psychologically, we've learned that it did not reach the patient. That's category A, B, C, and then D. Category E is a shift. This is where harm does reach the patient, and then it increases in level of severity from E to I. Category E, this is an event that occurred or an error. It contributed to or resulted in a temporary harm to the patient. It required intervention. That intervention includes potential for cardiovascular or respiratory support, including CPR, defibrillation, intubation, or an unexpected admission to the ICU. But again, this is a temporary harm. Category F, this is an event or an error that occurred. It contributed to or resulted in a temporary harm to the patient that required an initial or prolonged hospitalization. So the difference between F and E, we start to see an increase in the length of stay. So more prolonged hospitalization or required hospitalization at all. Category G, this is an event or an error that occurred. It contributed to or resulted in a permanent harm to the patient. So this is harm that will be permanent to the patient, despite all of our efforts to intervene. Category H, this is an event or an error that occurred, and it required intervention to sustain life. So here we're seeing a more intensive care intervention. Again, we are with the focus of sustaining life. So it's a very, very serious event. And the worst, of course, category I, this is an event or an error that occurred that may have contributed to or resulted in the patient's death. So again, keeping in mind, when I say contributed to or resulted in the patient's death, this is not related to the underlying medical condition. It's the event or the error that caused this harm. At Windsor Regional, as you know, we have a transparent, open, and just culture, and this is another reflection of that. RL6 reporting is not meant to be punitive. The values are that it's the importance of open reporting. It identifies process, policy, or systems failures. It helps us provide support to the patient. It helps us notify our patient advocates so they can be involved, support the patient and or the family, even help grant access to further health care or community supports that may be needed, including emotional supports. But RL6 reporting also helps us provide you support, the healthcare provider, emotional support, and communication training so that it doesn't happen in the future. Thank you very much for listening to my talk on RL6 reporting and this in-service that I'm pleased to present to you virtually. I look forward to presenting many more, and here in Legal Affairs and Patient Relations, we are here to support you. Please reach out if you have any further questions. Thank you.